Surgeons of Glasgow, United Kingdom. He is a recipient of awards like Best Teacher Award and Certificate of Excellence for Outstanding Service. He is extremely passionate about quality in healthcare and medical education and ensures that the same is accomplished in the world of healthcare. May I now invite him to deliver the inaugural address. Sir, please.
Good morning, everyone. Thank you for the opportunity to inaugurate this very important summit. Our chief guest, Dr. Jebamalai, whom I had the opportunity to meet in my chamber, I think probably a year and a half or so back, and interacted with him. And I also enjoyed the book on Modinomics written by him. And Dr. Vinanchiararchi, our old alumnus and also the guest of honor. Dr. K.C. John, our dynamic director of the Faculty of Management Sciences here at Sri Ramachandra. Dr. Mahesh Vakamudi, our Dean of Faculties. Dr. Selvam Jasaya, the energetic principal of the college. Dr. Purnima, the organizing secretary. Faculty members of the Faculty of Management here at Sri Ramachandra. Students and participants from inside as well as outside. And my dear friends, these are days when we keep doing webinar after webinar and meeting each other only on the computer windows. So much so that we even lose sight of the full figure of a person. Let me at the outset congratulate the initiative of the Faculty of Management Sciences at Sri Ramachandra Institute of Higher Education Research for actually thinking about and organizing the very important webinar. A similar one of it happened in December 2020 and now in November 2021, the second of its nature. And this is going to consider quite a lot of deliberations on importance of healthcare leadership under changing circumstances, and they also themed it as professionalism and beyond on a panel discussion format. This is one of the difficult formats to actually do it on a webinar mode, but I'm sure Selvam and his team would have planned it well to have it interactive. And on three important themes again for the panel discussion, we have got extraordinarily great experts from across the country to be speaking on the various subjects and also giving their thoughts in terms of innovation in healthcare delivery. That is the thing of the day. Every day when you open up the newspaper, you find something new coming up in terms of healthcare delivery. The other one is the smart diagnostics. Again, today in the US, every citizen probably holds a device by which he can probably find out if he is COVID positive or negative. To that extent, smart diagnostics has spread on to the common man. Digital innovation in healthcare. Again, this is the third concept that is being talked about and which will be deliberated. And these are all relevant for the day, not even today, but even for the tomorrow. And for any healthcare administrator, leader, or even a manager to be completely compliant with. At SRIHER, the Faculty of Hospital Management, that was the original starting point for Sri Ramachandra to get involved into management education way back in the year 2001, has developed a strategic plan, and we are extremely lucky to have the leadership role of Dr. K.C. John, who has shifted to our institution over the last 1 year and so, and he is leading the plan to develop this into a full-fledged business school, which I suppose it will be in place maybe by end of 2023. As leaders, we need to understand the basic differences between a leader and a manager on a broader note. We do understand that on the ground, many times we have sort of tracks of professionalism, and leaders become managers. Managers become leaders. I'm sure the senior leadership which is assembled here will understand what I mean. Leaders sometimes are passionate about the ideas that they think and project, and they start getting involved into the nitty-gritty and the logistics of minute management of the entire idea. And the manager starts thinking it differently, and they start giving their own ideas to see if something is implementable or not implementable. Leadership as a concept is all about thinking, analyzing, facilitating, and evaluating change, be it in the field of healthcare delivery or in the field of health professions education. In fact, leadership, even at the political level, should sort of look at these type of concepts. We also need to use the same set of gadgets for developing research in both verticals, be it education or healthcare delivery. We need to move from innovative preparations to evolutionary transformation. See, many times innovations remain as pilot projects, but they do not become useful as transformative changes for the hospital or for the entire organization. The past 18 to 20 months, COVID-19 pandemic has led to several leadership challenges, which required several changes on a day-to-day basis due to the changing needs and requirements. Strong clinical leadership to improve the quality of care provided to patients, compassionate leadership, and engaged staff delivering healthcare are the important principles that one has to follow. While healthcare professionals and personnel wanted to be frontline workers during this pandemic, the enforced lockdown and the difficulty in reaching the place of work, maintaining the prevention norms of social distancing, wearing personal protective equipments, and frequent hand washing and hand hygiene, and the fear of contracting the disease, which was poorly understood almost for the first 1 year of its existence. The social impact of isolation resulted in reluctance of some of the healthcare personnel into active work. To overcome many of the difficulties in purchase management, maintenance of various services, provision of equity at affordable cost in healthcare services, a separate administration was thought about by Sri Ramachandra under the medical director, and this was established with a director and an associate director of COVID services, who were asked to completely look at the varying requirements of COVID management in the organization. Patients were pouring in big numbers. India's biggest strength and weakness is the high population that we have. So we had to almost create a separate block for the management of COVID patients. We provided almost 40 to 50 intensive care beds at a very short notice, and we were also able to provide all the preventive regulations that needed to be provided in the form of PPEs and other gadgets. The work schedule was a big problem because people were reluctant to perform beyond 6 hours of work during this point in time, and we had to constantly look at our human resources in order to provide adequate care to the patients. The so-called unit system of functioning had to be abandoned, and more integrative approach were introduced, keeping in mind the long hours of work that was expected from each one of the healthcare professionals, including doctors. John P. Cotter, I don't think he needs any introduction to a management conference. I feel old is always gold. In his article as late as 1996, on leading change in the Harvard Business Review had suggested 8 important guidelines and steps to be followed to succeed in bringing out paradigm change in healthcare management. And I thought this article is worth for every student of healthcare management to go through to, as you know, sort of understand each of the principles. And I would just quote all those principles that he defined. Establishing a sense of urgency. It could not have been more apt for a situation like COVID than the first principle that he says that leaders should need to establish a sense of urgency when they meet with such type of pandemic situations or disasters. Forming a powerful guiding coalition. Now, this is another important job for every leader to adapt. As soon as you need to sort of create any new sort of issue into the organization, you have to create an ambassadorial group to actually deliver it. And that is to be identification is very important. You know the various principles of change management. You need to create change agents. And these are the people who are ultimately going to provide you the change. Creating a vision is another very important step. Many organizations develop vision only to be hung on the frame in the offices of the important officials in the university or in the organization. This vision, whether you develop it from bottom up or from top down methodology, should be sort of communicated to each and every employee of the organization to understand what is expected out of this vision so that they can bring forward the changes that are expected. So even in COVID, there was an article which the West Virginia University adopted this principle and developed a new vision for the organization. Because it was a pandemic, they had to completely revamp in terms of quality healthcare being provided, not only to COVID patients, but also to the non-COVID public that comes into place. Following the creation of the vision, the next important step is the communicating of the vision. You have to sort of make it percolate to the lowest level of employee in the organization on the vision statement that has been created. The next step is to empower all the stakeholders to act on the vision. So it is one thing to create a theoretical document. It is totally another thing to implement them appropriately. Now, this is where the identification of leaders and managers come into play. Leaders will probably create the document. They will probably help you in, but the managers, the implementers are the ones should understand that, and they should be able to take it forward in performing it on the ground. After this is done, then there are certain victories that have to be sort of created in short-term basis, because people get frustrated at the situations like COVID very fast. So there should be some sort of a incentivization and short-term wins and goals that need to be also defined in a situation like that. The seventh step is to consolidate on the improvements that have been suggested and producing still more change. Again, change is something which you cannot introduce wholesome, the idea, and sometimes it may fail because of that. So you will have to do it in a phased manner. And so you have to keep introducing more and more changes as the time goes along. Lastly, and this is the most important step, and I keep telling this in all my speeches anywhere, internalization of the approaches that have been sort of developed. Institutionalization, whatever has been thought about, I think people should buy it and people should be able to deliver it after purely getting agreed. If they get forced into something, I think things may not work. So these are some of the principles which I thought I will bring out for any healthcare organization to be, in order to do well. And I must quote the recent article that has come out and the Journal of Healthcare Leadership from the West Virginia University Hospital, one of the hospitals which practiced these principles and were able to achieve extraordinarily good outcomes under the COVID crisis. Now, COVID-19 forced us to adapt these changes faster, and 3 critical components for safe patient care had to be given prime importance. Now, what are those 3 critical components? Creating a culture of patient safety in changed circumstances. You know, patient safety could suffer for various reasons because of the newer norms that are being introduced. So we have to change this understanding and make some sort of a patient safety policies which are slightly different from the standard policies that we had developed earlier. Holistic continuous empowerment process. Now, obviously, everything cannot be dictated from the top. There are situations in which the local leader or the local person who is actually implementing them should be given some sort of a leeway, and which should be allowed. And this is the second principle that we need to also follow. Sustainability. After having done that, this can happen only if there is effective communication with the organization, and there should be continuing education on the various policies that have been sort of created. So guiding a leadership change would be the ultimate test of any leader. No business can ever sustain over a long term if it cannot reinvent itself, restructure itself. But human nature being what it is, usually complacency grows for many of the things that we do. The fundamental change is often with a sort of a resistance in mind, and that resistance has to be overcome, and the leaders have a big role to play in order to bring this change. The people who get affected most are the most difficult people to be changed. So we need to concentrate on those people, because ultimately they are the people who have to do the job on the ground. As I told earlier, leaders need to perform their job as leaders and allow managers to implement and work on the ground. Thus, leading change is both absolutely essential and incredibly difficult. Success stories of change revolutions are many, and I don't have to take this coal to Newcastle for an audience of management. And some of the success stories which I would definitely mention are the Toyota cars, how they turned themselves around by changing. Ford, General Motors, British Airways, Bristol Myers Squibb are other standing examples. I hope the present approach towards privatization of Air India will also meet with some success. Again, leading change can be under different banners. You can have change in terms of curricular reforms in education, technology enhancement in healthcare and health professions education, culture change, total quality management, which is a concept which is being understood more and more over the last 10-12 years, re-engineering and restricting. Some of these are some of the principles that we can work out for the program. Coming back to COVID-19 and leadership, after intense struggle and fight, nearly 45 lakh population across the world having lost their lives, amongst nearly 8 to 10 crores who suffered from the active disease as well. Poor diagnostic facilities in many of the developing countries, including India, we were probably not even able to diagnose enough number of people who suffered, and there were still quite a lot of COVID carriers in the world. And whether we have even reached herd immunity, we are not very sure, and we don't know whether we are going to face the third wave, fourth wave, and even further. So this particular pandemic has affected us in terms of education, engagement, entertainment, and economics in a big way. And I would like to end my inaugural address by quoting leaders like the President of the United States, John Biden, and our own Prime Minister at the recent global COVID-19 summit in the US, where nearly 100 global leaders had assembled either on the virtual platform or in person, and they participated. And the president quotes that the three critical areas that we probably have to concentrate for ending this pandemic. One is vaccinate all, vaccinate the entire world population. For this, we may have to do an integrated approach, save lives as much as possible. In the early part, the second wave, particularly in India, too many lives were lost for want of facilities. Third, build back a better world. So based on the experiences that we had undertaken over the years, over the last 1.5 years, we should be able to put forward practices which will build a better world for the future. I must at this point tell that all of you are into the portals of a highly quality university in southern part of India, namely Chennai, and the recent National Institutional Ranking Framework, an initiative of the Ministry of Human Resource Development, has given us the rank of 47 amongst nearly 1,000 universities in the country. The medical college itself stands at 14th, the pharmacy college 21st, and the dental college 8th. The College of Management also is taking a lot of steps to improve their quality of education, and they are getting their programs accredited by the National Board of Accreditation very shortly. I know I don't want to take too much of your time. I just thought the other important areas of leadership, healthcare leadership model should consider some more principles like what I told earlier: leading with care, sharing the vision, engaging the team, influencing for results, evaluating information, inspiring shared purpose, connecting our service, developing capability, and holding to account. Many of these principles are possible only with good connectivity and networking. And that can happen only when your e-governance systems and computerization improves. India has come a long way with the initiatives of our present Prime Minister in terms of connectivity, but there is still a long way to go in order to produce more important inputs into these areas. I am extremely happy to be part of this program, and I wish I had that time to listen to the speakers completely for the entire session of the day, but time and other preoccupations force me to move out after the inaugural is over. Thank you very much for the opportunity. Thank you.
Thank you, sir. Thank you so much for your insights in leading the change. Meanwhile, Dr. Vijayaragavan, independent consultant, has joined us. We welcome you, sir.
Thank you. Thank you very much. I'm sorry that my first computer crashed and the camera.
Over 30 years of experience in the United Nations Industrial Development Organization, Vienna, Austria, where he served in various capacities. He has authored several books and journal articles on the changing patterns of development, focusing on the key determinants on economic efficiency, ecological compliance, and social inclusion. His most recent works include Myths and Realities of East Asian Model of Development, India's Time, Rethinking Development Realities, and Intervene to Industrialize. He has won several awards, including Dynamic Indian of the Millennium Award, and recently Auckland-based Indo-New Zealand Business Association gave him a commemorative award for his distinguished contribution to the international community. And he received Lifetime Achievement Award from Bharatadasan University in the year 2019. Though he is busy with his professional life, he never turns down our invitation when it comes to sharing his wisdom. A man of mastermind and a renowned economist in the world. Ladies and gentlemen, please join me in giving a warm welcome to Dr. Jebamalai to deliver the keynote address. Over to you, sir.
Thank you. Esteemed Vice Chancellor, Dr. Vijayaragavan, distinguished panelists, and dear participants, I would like to express my profound sense of gratitude for the kind invitation from one of the prestigious institutions in India. I feel honored. Intellectual honesty tells me that I am not technically qualified to participate in this event, that too in the capacity of the chief guest of this seminar, because I am not a medical doctor. So when I received the invitation from my good friend, Dr. Selvam Jesaya, I was reflecting on the topic. I suggested that I would like to speak on the current digital transformative shift in healthcare leadership. I held substantive technical sittings with Professor Moni Madasamy, former Director General of the Informatics Center, Government of India, and I gained a lot of ideas from him. I have incorporated. So I would like to give part of the credit of my presentation, large part of the credit to him. He is actually participating. He just told me, he sent a message saying that the participants are not able to hear. I don't know if there is a technical snag, kindly rectify it. I forwarded the message to Madam Purnima. Can I request you to just present my PPT?
Yes,
Madam Rohini? Okay.
Yes, sir. Yes, yes.
Excellent. Okay, you can go to the next slide actually. Yeah, okay. Let me begin with cleaning the definitional ambiguities related to the current digital transformative shift in healthcare management. Let me read out what the real definition given. Digital health means artificial intelligence and machine learning based on platforms that aggregate patient data for apt intervention. I find a serious flaw in the definition. I think they should add the word smart mission before the word mission, smart mission. And they should also add one or two words at the end of the definition. Apt intervention for what? As things stand today, apt intervention only for curative interventions. Everything is curative intervention centric and does not say one word about preventive interventions. I think as an economist, this is what I find. I think the definition is not adequate. Now look at the various aspects, facets of the so-called health informatics. I think what is contained in the slide is self-explanatory. I don't have to read out. I am not able to find one word or one phrase related to preventive interventions. Again, a giant disappointment to me. As a patient, I am just looking at it as a patient. So all these domains are curative intervention centric. They do not address the root cause of the diseases. True healthcare leadership should encompass preventive interventions also. Please go to the next one, madam. Next slide. Yeah. If you look at the history of economic development, rapid, revolutionary, and complete changes were triggered by technological marvels. The incidence of technical progress went deep into each and every aspect of producing, processing, and marketing products. This is what we learned. First, second, third industrial revolutions were triggered by fast changes, triggered largely by technological marvels. And today we talk about the Industry 4.0. Industry 4.0 is underpinned by disruptive technologies. These disruptive technologies are actually pushing us to the state of creative destruction. We are living in an era of creative destruction. These changes make old things stumble, and every time we have to be tuned to the rapidly changing facets of whatever we do. Disruptive technologies are advanced digital production systems, artificial intelligence, augmented reality, then additive manufacturing, big data management, cloud computing, then 3D printers, electromobility, Internet of Things, Internet of Services, Internet of Energy, and even now talk about MindNet, which is very dangerous, to be honest. MindNet. So, in an era of disruptive technologies, we are facing what is called a disruptive, creative destruction. Now we just move to Industry 5.0. That's very narrow definition. We are all conditioned to work hereafter. What is the future of the workforce? Recently, the World Economic Forum published a document on that. Ford Foundation published one on the same subject. I went through the two reports. The real summary, it can be summarized in one sentence. We are all conditioned to work with, we will be soon conditioned to work with smart machine, robots, and artificial intelligence. So health sector is no exception to this trend. I would like to spend 1 minute on the difference between digitization and digitalization. Digitization entails storing data in digital form, pertinent data related to anything. As an economist, I would like to store data in digital form on data related to new and dynamic sources of growth. I am sure it is applicable to health sector also. And then digitalization means you just use the digitized data for effecting improvements. And then the primacy of digitizing and digitalization in effective health leadership could be understood in different ways. Please go to the next one. Yeah. What is expected of any institution dealing with the health sector? The minimum is to create an inventory analysis of the frontiers of best practice in using digital technology and devices in medical interventions. I don't know how many institutions do. That's a minimum. That's a starting point. You cannot plan without figures. So once you create that inventory, I said inventory analysis because each hospital is armed with the experts, specialized experts with several years of experience. I used to say experience is the richest institution. You know, you can Google anything except experience. So this talent can be effectively used for analyzing the inventory data related to the frontiers of best practice in whatever you do. And then next one is to see your distance to the frontiers of best practice. You don't have to replicate the best practice within a day or two. Minimum is to know where you stand. What is the distance? And then try to identify viable avenues of reducing the distance to the frontiers of best practice in medical interventions. Please go to the next one. Okay, simple example. You know, MBBS doctors who often serve as general practitioners, for me, they are the nerve center. They constitute the nerve center of the healthcare because patients normally go to them for their advice, and these people ask them to go to hospitals or start treating them also. So they constitute the nerve center. My question is, do general physicians keep a copy of their prescriptions and proscriptions? A doctor may see 100 patients a day, and he picks up the chit and prescribes and proscribes. Does he keep a copy of that? Are general physicians aware of medication tracker apps? Someone told me that around 35 apps are available. I don't know. I'm not an expert on this. I just checked with somebody casually. He said more than 30 apps are available. Are the general practitioners aware of that? If at all they are aware of it, are they using that to monitor the progress made by the patient? Then what is the percentage of general physicians using medication tracker apps? I think it is meager to the extent of being negligible. This is the ground reality. What is needed is effective knowledge dissemination about the usefulness of all these things. And okay, you can stay here. It's okay. Please go to the next one. So, having said that, I would like to reflect on the key facets of digital health care. They are all very good. Almost accurate diagnosis. It is always believed nothing is 100% in medical science. You make a guesstimate, estimates, and you as doctors, you know that nothing is 100%. But when you use the technological marvels, the digital healthcare system, and highly sophisticated technology, I think it is almost accurate. I was able to say 100% accuracy in diagnosis, but I took the liberty of putting the word almost accurate diagnosis subject to human error. Intelligent digital solutions, again subject to human error. Digital capability enablers and high degree of precision in medical interventions. And what is the outcome? Which is very good, very encouraging. Dramatic increase in survival rate as evidenced by facts, as evidenced by empirical evidence. Okay, please go to the next one. Next one. But there are issues we cannot afford to ignore. Key issues posing healthcare leadership. How could healthcare leadership make highly sophisticated digital-based diagnosis and treatment within the means of the poorest of the poor? This is the major issue. I'm from Kanyakumari, and Nagarkovil is well known for best medical treatment. A patient goes there with a mild headache or anything, and he's hospitalized. If he's hospitalized for 3 or 4 days, sometimes I have seen families selling their properties, selling the paddy field, selling the coconut plantation, selling the jewels. I used to wonder, what is this? What type of this? One big hospitalization is leading to the very high cost, which is definitely not within the means of the poor people. I think this is, if the healthcare leadership could make the highly sophisticated healthcare treatment based on digital interventions, I think that will be a major contribution to society. And sometimes you go with for mild, the very small problem. I think sometimes in some hospitals they overdo. Immediately they ask the patient to go for this test, that test, and this and that. And after 5 days, a minister told me he was examined for 5 days, and to be told that you are perfectly all right, please go home. And what is the cost? At a very high cost. I have a lot of respect for Indian doctors. Having lived in Vienna for more than 35 years, I really inculcated a lot of respect for Indian doctors, because when an Indian doctor touches the human body, he knows how the whole system operates. I will give you one example. Once I collapsed in the living room. My wife immediately rushed me to the Kaiser Elizabeth Hospital in Vienna, which is located very near to our house. And the doctors came and they said, "You are from which country?" "India." "Did you go to any tropical, did you go to India recently?" I said, "No." "Did you go to any tropical country?" "Yes, I went to Nigeria." And immediately they said, "You are suffering from malaria." And they already decided. So just for the poorest reason that I went to a tropical country, the decision by the doctors was on. So they sucked, I think, 12 tubes of blood from my body to see whether I am affected by malaria. Series of tests. So my wife came in the afternoon and asked me what is going on. They are suspecting malaria, and they have taken 12 bottles of tubes of small tubes of blood, and they are conducting series of examinations. And there, unless they diagnose something, they will not start the treatment. You know that. Then next day, again, they could not find any trace of malaria. They again took blood, I think 6 bottles. This time it was less. Again conducting further intensive examination to see whether I was suffering from malaria. Third day, when my wife stepped into my room and asked me what is the latest, I told her they are waiting for malaria to come. This was my comment. And this would not happen in India, you know. Within a day, they will find out and they will prescribe something, and on third day or fourth day, you will be on your feet. Now, are we overdoing? This is my concern. I think healthcare leadership address. The next issue is, can health informatics value chain network address the root cause of disease? I am going to elaborate it in the subsequent slides, and I would like to recognize the contribution of Professor Moni Madasamy. Now, can it address the root cause of diseases? We eat unhealthy plants, unhealthy animals, unhealthy fish, we drink unhealthy water and breathe unhealthy air. Is the healthcare leadership attempting to this to address the root cause of the diseases contained in all these things, what I explained now? Then is it possible to use person-centric digital healthcare to decouple patients from doctors and hospitals? I think even WHO is now coming out with a program to decouple patients from doctors and hospitals. Tamil Nadu government's recent announcement, Makkalai Thedi Maruthuvam, is part of it. They don't have to go to the doctor and they don't have to go to the hospital. And given today's technological marvels, you know, when someone suffers from something, using the symptoms, he can Google or use a search engine and see what is it all about. He can even understand the exact magnitude of the problem and also attend to the curative interventions to some extent. I think decoupling the patient and patients from doctors and hospitals may be a very good initiative. Is it possible to use then how to use digital healthcare to optimize the proven benefits of traditional medical knowledge and practices? In the wake of COVID-19, we are increasingly realizing the importance of traditional medical knowledge, traditional medical practices. Actually, in the sphere of medical healthcare, and we are back to the future, and it is proven to be very, very useful. So, can all these digital healthcare interventions optimize, create a unique blend of both, then responding to the unexpected, as rightly said by the Honorable Vice Chancellor, you know, rapt attention and apt response. This is very, very important. I will just tell you today's situation. I was actually in India. I landed 2 weeks ago in Vienna. I just asked about the problem, a COVID issue here, and they said nothing, hardly 65 in Vienna, in the country, maybe 120. You may not believe today is just 10,000. So you expect the unexpected. And as one of the speakers nicely said, optimize our interventions to accommodate more patients, how to do that. And when suddenly you are pushed to a condition to treat 10,000 patients in a country like Austria, where only 8 million people live. Now it's a big issue, and the system responds very well, they address it. And I could say amazing response in institute. I think they even reduce the number of outpatients. That's the first thing they do. And then they change the priorities. You know, very critical cases are attended to, others are postponed. I think the healthcare management leadership is working very well in Austria. And life as usual now. Yesterday, I took my guest to a nice Greek restaurant for dinner. Of course, there are some conditionalities imposed on us. We have to show some certificates and this and that. And with that, life is as usual. So I think our capacity to demonstrate rapt attention and apt response to unexpected developments is very, very critical. Please go to the next one. Next slide, madam. Yeah. The future we want. What is the future we want in healthcare leadership, and particularly in the sphere of the so-called digital transformative shift? Digitalized, integrated health management system, linking human health, plant health, animal health, soil health, fish health, water health, and air quality. This is what is called integrated, digitized, integrated health system. If you concentrate only on curative interventions, and completely ignore the preventive interventions needed, I think we will not add to the correctness and completeness of healthcare leadership. Please go to the next one. This I got from Professor Modi Mansam. I very sincerely request Dr. John and Dr. Selvam Jesaya to invite Professor Moni Madasamy, and I discussed it with him, to offer an optional subject covering all these aspects: health informatics network value chain. I think this is very, very important. I am sure many students will prefer to do that. And you look at the components here, the public health system, then plant health system, then animal health system, then fish health system, and then soil health system. And that's also very important, soil health. We believe that all the ingredients contained in the soil are meant by Almighty God to strike a balance in animal metabolism and human metabolism. When the soil is completely ruined, I am sure health-related problems will surface. That's also very important. Water quality system, air quality system. So I think this is the need of the hour. Educating people on health informatics network value chain. It is in the value chain. Value is added to raw materials to earn huge margin. The prosperity is essentially a matter of value addition. If you don't add value, you don't grow. The African countries, take the example of African country, each commodity is a tragedy. Coffee tragedy, tea tragedy, cocoa tragedy, palm oil tragedy. Look at this. Oil palm was originally transplanted from West Africa to Malaysia. In Malaysia, the tree is a potential source of wealth creation. In Africa, it is still a tragedy. And today, Malaysia is establishing palm oil research center in West Africa, from where the plant was originally transplanted. It's a tragedy. So what happened to this particular product? Because in Malaysia, they applied science and technology to each aspect of the efficient farm management to producing around 83 varieties of value-added products, and booming like anything. And that's a principal source of wealth creation in Malaysia. So value addition, but in the value addition, many private sector stakeholders misbehave. When they misbehave, all these health-related problems will come. I think the healthcare leadership cannot afford to ignore this. And next one, madam. Next one. Go to the next one. One nation, one health system by 2030. Okay. The policy of the government of India envisages to integrate modern traditional systems of medicine like allopathy, homeopathy, Ayurveda in medical practice. Last time when I addressed the participants, I made a reference to this, and I quoted one Latin American doctor who said that if allopathy doctor knows only one, his subject, and does not know anything about related subjects like homeopathy, Ayurveda, Siddha, and he does not know his own subject well. This is what he said. I think the government's programmatic accent is on that. So in order to translate this into deeds, what should I do? This is my humble opinion. If you are very serious about it, establish a central university of holistic medicine in each state. Why can't we do that? When I sent the PPT to Dr. Selvam Jesaya, he asked me, what is holistic medicine? We never heard of it. I coined it. It may be wrong or right. I think my common sense tells me, if you are serious about it, you should really establish a center, a central university in each state to have a unique blend of all these medical interventions. I call it holistic medicine. It is subject to correction. Then next one. Next one. Yeah, this is the last slide I want to say. I want to make a reference to the key message of WHO report on global strategy on digital health by 2020 and 2025. Again, please look at all the words and phrases. Everything is curative, intervention centric. Unfortunately, it does not say. Now, see, 13, like one sentence with commas, with no period, not even a semicolon, with several commas, covering 13 lines, and not even one word related to preventive healthcare intervention. This is what is called the poverty of scientific thinking.